Thanks very much. So good afternoon again to everyone who's joined us. So this is the third installment in our series where we've been looking at the application of health system science as a discipline, but specifically looking at how we can apply systems thinking across health science education and beyond. We started off with a reading group, and we read an article that was based on nurses' experience of challenges that nurses face when they enter into the workplace, and how to then take a few steps back and look at how we could better train people to prepare them for complex health environments, particularly dealing with teamwork, communication, and a number of other competencies. And one of the key points was that we have to teach a way of thinking through systems and thinking through links between various component parts and how they all link to each other, so that graduates can start to see how these things unfold when they are in the workplace. We had a follow-up where we looked at some of the tools that we might use in our programs or courses that we could maybe apply to different settings. And some of these came from suggestions from the reading, and others we added following some of the work that we've been doing in courses like health system science and medical and health humanities. So just a quick recap, what we were proposing is that we should take a learner-centered approach through kind of a learner excellence rather than a teacher-centered approach, right? And that facilitates a form of systems thinking. And we presented very briefly the deep and meaningful framework, learning framework, that suggests different ways in which we can be more centered or focused on students and their learning journey over the course of their academic career. We suggested that central to that was the use of a competency framework, and what the work that we're doing in the faculty at the moment is looking at developing a non-clinical competency framework that would be relevant across all programs, be they clinical or non-clinical, in health spaces. What do students need to be able to do when they enter into the workplace or into the health sector, and how would we define that, and then how would we again retrofit that into our program so that we create spaces for learning, modeling, and so on. We also, this came out of the reading, the suggestion that we should develop opportunities for interprofessional education or peer-to-peer learning, that we should look at opportunities for putting different groups of students together around the kinds of systems challenges they might face in the workplace, and then seeing how they can draw on the competencies of different groups of people to achieve or to find solutions moving forward. And then also getting the perspective of clinical students, for example, for what they encounter on a day-to-day basis versus non-clinical students who are thinking perhaps around things like policy, management, administration, how these two worlds combine. We suggested similarly that it is useful to look at complex situations through multiple lenses. So we would need to take a step back to see the bigger picture, and ideally we're trying to see a holistic picture, but at the same time we can see a complex issue from multiple perspectives, and this gives us an opportunity to teach content areas such as health advocacy, ethics, history, and we mentioned a few of those that we've been using to give students a better context around why things are the way that they are, and how various perspectives allow us to see new and perhaps unexpected opportunities. We then suggested that using a writing intensive approach, and it doesn't have to be writing intensive, it can be writing rich. This is something that the Writing Center is pushing, that we build opportunities for writing as critical thinking into our programs. Writing goes alongside academic reading. How do we get students to to read critically, to pick out arguments, to understand the underlying warrants within claims that are being made, to be able to use or appropriate those claims, or to see how they can be manipulated in different contexts that could be a reason for why we have the kinds of challenges we have today. So being much more critical about what they read and how they read it and how they use that to make claims in the world. This could also apply to the, I guess, the ontological basis in which biomedicine is situated, drawing students' awareness to all of that stuff and getting them to read and to write through those. We suggested different forms of writing could be useful. Reflective practice is, of course, something that's common in medical education, but how to teach that and to use it. And then to kind of draw this together, our last suggestion was that we need to be more flexible in our assessment approaches to allow for systems thinking. One of the reasons for that is that systems thinking takes time. Hey, I've got electricity. Systems thinking takes time, and so does the students' learning. Competence, of course, does not. You can't teach something and it immediately happens. We have to allow students time to develop competencies and to see their applications through their learning journey, and to think beyond what they're learning in the classroom to the real world setting. Can they see the relevance of what they're learning from how they engage in the world? And so we suggested that one avenue to do this is to develop a portfolio of evidence of learning where students can compile evidence of their work back on it. Something that draws out the key learning points, but that take time for students to see those links. And similarly, there is no right answer often in this kind of practice, that we allow students to justify or think through, for example, a lens that they choose to apply, and then to find appropriate evidence to support what they're saying. And if that line of logic is clear, then we feel like we've done our job. So that's part of approaches or tools that we were suggesting for teaching systems thinking in our space. I'm going to share my screen, Catherine, and then perhaps just take us through some just to elaborate on those ideas a little bit better. Only meeting organizers and presenters can share. I see, Christine, that haven't been made a presenter. Have I just logged in with the wrong thing? Christine?
Usually it automatically fixes itself, but I just changed you to presenter.
Thank you, appreciate that. Okay, I've got lots of things open on my laptop. Let me just see how to share this. Is that presentation mode?
We can see it, Stephen.
Okay, I'm going to put it into that presentation mode so that you see my full screen. Is that better? Perfect. Are you seeing my full screen? Perfect. Great. Okay, so this is what we're trying to do today, is to look for opportunities in our own courses. And so as we speak, perhaps what I could suggest is to have a piece of paper next to you, just thinking through your kinds of engagement, wherever you're coming from with students, and as ideas perhaps come up, just to jot them down to see whether any of these things might be relevant or whether there's spaces to engage with it. The first thing I thought was useful is to present what's called the iceberg of health concepts. And perhaps this is a bit biased, but what it's saying is that the focus of most medical education programs is obviously on the care that's provided to individual patients and the kinds of skills and clinical skills that have to be developed. But underneath that, there's a whole bunch of stuff that obviously impacts whether or not that care is provided appropriately, and the manner in which it is provided. So here we see teamwork, collaboration, team science, the need to have a readily available information to make decisions, and looking at intersectionality, understanding the role of determinants of health. Where do we send our patients after we see them? Where do they come from? What are the conditions in which they're living that can impact the outcomes? Seeing the link to policies, what's actually in place to assist us to do what we're doing, the various forms of leadership, thinking through the integration of different systems to achieve that goal, understanding the broader picture or population health dynamics, how important are the issues, what are we seeing on a regular basis, bringing value to healthcare, being proactive and patient-centered or person-centered here. I think it's different framing it as person-centered versus patient-centered. So seeing ourselves as people also in the system, and ultimately working towards improving the health system. So there's many of the models, of course, that we focus on in health system science are around quality improvement. How do we actually identify a challenge and actually start to work towards that? And we'll discuss some of that a little bit. A typical framework that's used in health system science is this is something that's dominating thinking at the moment. We've adapted this a little bit, but the concepts can be adapted, I guess, to different disciplines too. What we have at the center is the focus of what we're trying to do, which is essentially, we can argue that all clinical disciplines are trying to improve patient outcomes and health outcomes, and that we can focus create a focus on the patient or the person within their context, recognizing that people are people because they belong to other people, families, communities, and so on and so forth. So that can be a point of departure that is a shared commonality. In the center of the circle are the various core curriculum material that make up a discipline. This is what has been suggested for kind of core concepts or that need to be understood in health systems. For example, understanding what the healthcare systems and structures and processes are. How do things, what has to be in place? How do things work towards health outcomes? Being able to link this to healthcare policy, understanding how health systems are funded, the role of informatics, and so on and so forth. So these kind of core areas, I guess, can be adapted depending on the discipline. What's surrounding that are cross-cutting competencies or content domains, things that are relevant across various components within a discipline. When this model was first started, there were more than 4. Now they kind of lumped them together and renamed them. But like, for example, rather than talk about collaboration, they talk about teaming and teamwork. So these are the kinds of things, these cross-cutting competence or content areas are the kinds of content that we can use to build interprofessional learning opportunities between programs. For example, change agency at the bottom here, or advocacy, is something that is relevant for various people. And of course, the positioning of the graduate is they need to recognize where they fit into that, and understanding different kinds of complexity, like a dual loyalty for people working within the health system as clinicians versus people who might be working in the NGO sector, and how these things might link up. And then, of course, surrounding all of this is this developing a systems thinking. How do all these things interact? Understanding the various component parts and seeing the connections between the component parts, trying to predict outcomes, but also being aware of unpredictable outcomes from systems, from changes within health systems. So this kind of framing allows us to see opportunities again for how we might create learning practices that stimulate what we've been saying previously. How do we develop interprofessional education, peer-to-peer learning, student or centered learning approaches, and the kinds of themes that I guess cut across our programs. And then what I've got here is are some of the habits that we are trying to instill in our students, and we can inculcate these habits through the kinds of activities that we we present students with, and of course through our assessment practices too, to see whether students are able to recognize some of these key things. And of course, a habit is something that we develop over time through repeated practice. So we can't just expect students to be able to do these things. We have to model it, show how it's relevant, link it to authentic situations and authentic assessment opportunities, and so on and so forth. So similarly, this has to be done within the context what we're proposing of a deep and meaningful learning philosophy. So the first one, for example, is that one of the habits of a systems thinker is that they seek to understand the big picture. This is pushing against kind of reductionist thinking in many disciplines. Of course, it's logical that clinical disciplines have to focus on specific things, but it runs the risk of our thinking becoming very reductionist. How do we take a step back? Obviously, when we think about how people work within a system and how things are interconnected, how do we create that? This links actually quite nicely to the one in the bottom where we right-hand corner, changes. That is one of the habits is changes. They are able to change perspectives to increase their understanding. So I feel those two things are linked in the way that to see the big picture, we have to have various perspectives on what's going on. And what we've been proposing is that it's essential for anyone moving through our faculty to have some kind of historical perspective in terms of why things are the way they are, how far back do those go, how are they rooted, and how are things structured or created. Some other habits are observing how elements within a system change over time, generating patterns and trends. And again, we can link this to students learning or developing competencies and how their practices change over time. But this again links to our focus on an historical perspective, why it's important to see where we are now, but being able to understand how we got there. And then, of course, there are other disciplines that come in here, like epidemiology and biostatistics that might be able to quantify or picture change over time. Of course, I was having a discussion, this is not of course, but I was having a discussion with Catherine previously, just when we were discussing how to present this, around how we then bring in a critical lens to the ways in which we picture or present changes over time. And here we see an intersection with the medical humanities, who might be much more critical of this. And I'll ask Catherine perhaps to give an example of that. I don't know if you want to come in here now, Catherine, or do you want us to just to work through some of these first?
Maybe an example would, and then you can dip back in again, would get people in the room to ask some questions, Stephen. So, here's something quite provocative, hopefully. And this would help us, we can frame it with seeing the big picture, how we generate trends, how one form of a system, such as the guy's kite, interacts with the young woman's little whirring windmill, and how all of these things produce a kind of tension or talk in the system. And that in order to change our perspective, we have to get out of our comfort zone, kneel down, stand up. So when the HIV pandemic emerged in South Africa in the middle of huge contestation about its causes, its pathways, how it could be explained, how it could be charted, and then, of course, how it could be treated, how it could be halted. One of the things that immediately came into focus is that in epidemiology and in demography, the tools that people had perfected around sentinel studies, which also infectious disease doctors used a lot, and nurses and other clinical people used in tracking other kinds of emergencies, immediately came into view. And within a few weeks, all of you will know this, it was decided, and I'm using the passive voice there, like who decided? It was decided that we would use blood samples taken from women of childbearing age presenting themselves for prenatal or antenatal care because they were already part of a health system. There was already a whole set of protocols around this. There'd already been an established and long history of physical samples being taken from women who came in for pregnancy-related care, which would include blood, swabs, palpitations, measurements, etc., and files would be open. So there was a documentation platform, there was a physical tissue platform, there was a behavioral cultural expectation platform, and of course this was highly gendered and specific to a certain age group of women, but it was also the age group that ethically everybody felt was the target group. And so all other issues being equal, it was decided that if the data was anonymized, this would move ahead rapidly as the way to try and figure out what HIV incidences and later prevalences were. Of course, the consequences of this were far-reaching. It meant that men were never drawn in to sentinel surveys. It meant that in cultural and in other ways, legal ways, women were seen, even if this was absolutely not the intention, as the carriers and causes of disease. Suzanne de Klerk-Matlala's outstanding thesis called Demonizing Women specifically looked at the implications of this demographic and epidemiological decision. It had huge implications later for the law, as Constitutional Justice Emeritus Edwin Cameron showed, and it also had repercussions for the particular nuances of the health data. Could we have done it differently? I'm not sure, but it was normalized and it was very, very hard to get men into testing and care. And the data that we drew from it to this very day still focused on that group. The only exception was men in the South African National Defence Force post-liberation. And then there were huge court cases about how it was not acceptable to demand or expect this kind of data from men when there wasn't follow-up, cure, or unless there could be very good care. And that this whole debate took place in the South African courts, but there was never any contestation over how this would be collected for women. So this grew out of an already existing health system. It made sense to all the people involved. The numeracy qualities in it, the arguments about efficacy and scientific plausibility were high and legible to the participants, but all of the basket of other consequences from this and all of the ethical and legal arguments that were made for men, which weren't made for this, are still outstanding in our social fabric. And of course, what it links to is the question of care. Ethicists have often told me that what finally decided them that this was much better glass half full than half empty is that we needed this data immediately and that this was linked to care. The fact that it was linked to pregnancy care rather than care for people suffering from HIV initially was an issue that people stumbled towards. But it would be very interesting to see what people in this room would think about assistance analysis of this normalized and very seldom discussed aspect of epidemiology and demography.
Thanks for that example. It's really interesting. Yeah, so we also teach something that's not quite the same, but it's linked to understanding incidence of disease. And the example that we use comes from a student who is a master of nursing who recognized a trend or a pattern that in the rural area where they were working during the December period, they would see a sudden increase in the incidence of HIV, and then it would drop, and then they saw this again. And when they actually used a qualitative approach to understand this, they went and asked people, well, why? Like, is this the first time that you're testing positive? And they would come back and say, well, no, it's easier for us to just go in, get the test, and then be initiated on treatment, but rather than try and get a referral letter from where we work normally during the year in another province, because those processes are so broken. So we just come in, we test, then we get initiated on treatment, and then we have our treatment while we're there. But then of course that through the statistics completely. But people make sense of a system to make it work for them. Is the argument, right? But of course, the knock-on effect was that people, funding agencies were starting to, pour money into rural health, which is not a bad thing, but obviously trying to understand why is this pattern the way it is. Yeah, so another thing that's important to recognize here, or habit, is recognizing that a system structure generates its behavior. And here again, this is why I'm going to push this, Catherine, why we have to teach the history of our health system, because our health system is violent towards many people, and doesn't have a caring, humanistic feel. And we know that healthcare workers are often blamed for being unkind or rude and so on and so forth. And that has nothing to do with the people themselves. It has to do with the structures that generate those forms of behavior, or that reinstate them or reproduce them. So understanding the categories that have been historically formed are important. Understanding why, these things have multiple come from multiple places. A shortage of staff, for example, a lack of feedback coming down to staff, and then I think also links to the picture below, which is about identifying the circular nature of complex cause and effect relationships, really seeing causal loops, how things are interrelated and linked, and seeing that something that might happen in one space can have a knock-on effect elsewhere. How do we encourage that way of thinking? Of course, it's important for systems thinkers to make meaningful connections within and between different systems. So recognizing that health does not operate in isolation. Again, here drawing on social determinants of health, and seeing people as existing outside of the health system too, and then also seeing that as a resource. How do we see interconnections between different systems that can impact health outcomes? And so there are more. There are 14 of these habits. They come from the Waters Foundation, and there's a description of each of these actually within the context of physician education. But I thought again that these could be useful in stimulating our thinking around the kinds of tasks we might want to set up in our courses to get students to think in a systems way. For example, what you've just mentioned here, how do we surface and test our assumptions? How do we think about the categories that are created, where they came from, why they were formed, that we might just be using without any critical thinking? Are there better ways of capturing the same phenomenon, for example, or why do people make the decisions that they do make, and then where do I situate myself in terms of my own kind of cultural or whatever the background from which I come that might shift the kinds of assumptions I make about other people. So I guess this is also an opportunity for students to develop their own sense of self, but also to be critical of their kind of learning, and that's an opportunity for us to show them how to be critical of that. Considering an issue fully and resisting the urge to come to a quick conclusion is again a practice we can show students again how do we think through solutions to complex challenges. We can't just be putting band-aids on everything, and what happens when we do. Considering how mental models can affect the reality, our current reality and our future. This is again an opportunity for introspection. What is their perspective? How do they see the world? How does it negate other ways of being or seeing? And what kinds of things have they been taught that make them act or practice in a particular way? Here, also importantly, using the understanding of the system structure to identify possible leverage actions. This is really about getting students to see that change is possible, that even in fragmented or challenging, complex health challenges, that there are ways of starting to affect change meaningfully. I think a lot of students, when we teach these wicked problems that they encounter, might feel quite despondent about not being able to change things, especially when we throw a political spin on it, and people feeling, well, they're politically silenced. How to show examples of small actions having big effects, and then being able to identify where are the best areas for systems change. Considering short-term, long-term, and unintended consequences of actions, of course, also very important. This again is linked to thinking about actions over time, and developing, recognizing patterns and changes over time. Getting students to think and plan about what might happen, what is immediately needed, and where do we want to go, and what might we not predict within a system. How can we start, or how can we think about how we would address those issues? Paying attention to accumulations and their rates of change. Now that I see this, I can't remember what I wrote about this, but I guess it's again change over time. Like how can things build up and shift and change, and getting students to see those patterns when things come to collapse, for example. Recognizing the impact of time delays when exploring cause and effect relationships, and the final one is checking results and changes actions if needed. So successive approximation. What to check results and changes actions if needed. Oh, right. So recognizing that we can make mistakes, I think, is important. Looking at what happens. This is very much linked to monitoring and evaluation. Seeing what is the impact of our actions, and being able to make necessary changes along the way, and not necessarily just sticking with the status quo. Of course, there are contexts in which that is not always appropriate, but it is a question, I guess, towards working towards systems improvement, recognizing that things cannot remain static, that we have to have flexibility, adaptability in the way that we manage and address complex challenges. So I just thought that these habits were helpful in getting us to think through the kinds of activities we might want to propose to students. Do you have any thoughts here, Catherine, before we move on?
Well, I'm looking at the questions and the comments coming up in the chat, which are interesting too. And Daniela's asked, what are the characteristics needed in an educator, and also I think the learning environment, as well as other environments, to get a good level of interest in this kind of material? And then Anastasia offered a very pragmatic intervention, which is also, I think, very useful. People make sense of a system in order to make it work for them. So if we can make the link between understanding a system and making it work, connect more seamlessly, then there'll probably be much more buy-in, even instrumentally. And so I'm appreciating that. But I'm also often struck, and I wonder if Stephen is too, and the rest of you, about how in this country, we live through a period, and those colleagues amongst us who come from other countries on our continent will have grown up with a very different space around them, but looking often, I'm sure, as young people with horror at apartheid South Africa. Not many of us are alive in the room now that were alive before 1948, but there could be some of us, so we could be looking back even to segregation era, when a whole lot of norms were put into place, including at Wits University. For example, you had to be of the same color to treat a person if you were black, but not if you were white. White doctors were seen to be able to treat anybody's body, white nurses, anybody's body. But it was only religious sisters originally in the missionary denominations that treated black patients. Later on, white nurses and nurses of all colors treated all patients, but black doctors were prevented from treating white patients or patients that were not of their same ethnicity. For example, if they were South Africans of Indian descent. And this ludicrous set of norms and assumptions, which created an entire perversion, a gross perversion in the health system in South Africa, which we're still struggling to emerge from. I can't think of a single doctor, nurse, clinical associate, or any researcher or scientist worth any space in our public domain would be able to make those kinds of claims now or set up any system on their basis. And yet so many of our students and colleagues don't know about this history. So how do they make sense of the perversions in the system, the tensions, even the psychosocial dynamics, and even, I would argue, some of the subconscious stresses and tensions that arise and become points of great conflict around authority, around claims about truth, around cultural appropriateness and sensitivity. And so, you know, once again, a norm that was established by a small minority and that had pervasive structural harms on people, which gets unpicked at the legal level from the top down, but the ramifications of which are not fully disemboweled from the structures, and where the actual ideology is utterly repudiated and completely nonsensical today, but which the echo effect still remains with us. So I think that knowing this and this temporality helps people to think less fatalistically. First of all, how catastrophes happened, what caused them to happen, how people were swept up in supporting them, but how people broke them, how people insisted they were wrong, how they persisted, and how they began to find stitch-arounds even the darkest of days. So maybe I'm giving an example that seems now too much outside of clinical medicine, whereas my HIV example perhaps was much more prescient. But there's another one I'd like to draw on, bouncing off Anastasia's comments and obviously Daniela's. Stephen, over to you, and maybe invite people to come in as well.
Yes, yeah, just a last thought in terms of one of the approaches, again, tools that can be used. What is often proposed for systems change is to apply an adaptive action. And this is quite a simplistic way of just describing it, but it's really when we're seeing a challenge, or can we describe and understand where it's coming from? So what does it look like? Obviously, with complex, wicked problems, that's much more complex to do. But what we would show are things that where there are opportunities to start to shift change. For example, if the issue we're witnessing is poor staffing attitudes, how would we describe that? What does it look like? And then the so what is, so what does that mean? What is the consequence of that? Like, it's the why, really, because why is it important? And then the now what is, now what do we, once we understand that, and we see what the consequence is, what do we do about it? And that's in the now what we look for the low-hanging fruit. We look for the easy gains to start to shift and make changes. So like, obviously we can't change this complex thing over time, but we can start to make small shifts. And when we do that on multiple times, we start to see changes over time, to hopefully towards some kind of improved outcome that we've identified. Catherine, yes.
Stephen, just one thing I wanted to bring up, which came up a bit last time in the questions, is that when many students and many of us think of something that's a system, we think of something that's the opposite of adaptive. People will say, oh, we can't do anything about this. Say, if you go to Home Affairs for a document, it's the computer system. Or we can't do anything about this because it's the system. It's, in other words, something outside of our control. It's like above human ingenuity or individuality. And it's somehow locked away from all these adaptive models that we've been sharing with people. So, you know, I think that we address this, of course, in the HSS courses by looking at very small adjustments, almost micro adjustments that people can make any particular space that they are in slightly better. And this can be with very tiny wins. But at the same time, they have to think at scale. So it's the scope and scale paradigm all the time. Mostly HSS is taught in many countries of the world without a strong historical lens. But luckily, I think with Stephen and other people's leadership, we haven't been falling into that trap in South Africa, which I think would be a very foolhardy to do. So then temporality also comes into it. What's my goal for a year? What's my goal for 2 years? And then we can make very small but measurable goals. The measurable goals then can be used to reinforce claims around science-based and evidence-based solutions, which can then draw in people across political and other ideological or professional divisions and give people very great encouragement to keep moving. So I think it's that cycle that you depicted at the beginning that's so key.
Yes, agreed.
And you can see, Stephen, we've got some people here from the Department of Health, Gauteng Department of Health. We've got some of our esteemed colleagues who have been working with the Nelson Mandela Fidel Castro platform. We've got some of our family medicine doctors. We've got clinical associates here. We've got people in health system science. We'd love to take questions from people, or we'd love you to challenge us and yourselves with a very difficult conundrum that we could maybe think about a health systems approach helping you with in a particular pedagogical setting.
Yeah, that's actually where we're going to next, is what kinds of themes could we consider as a collective from different vantage points. I think we're taking the root of this is to see how we build or improve our curriculum towards achieving these ends, and so what we've been discussing around some of the approaches that we could use. But often one way of cementing it is by finding common ground, the kinds of themes that perhaps could be used to link different programs, and then the different kinds of perspectives that we could then draw on to show how they would be relevant from different spaces, and putting people together then and sharing their thoughts towards applying an adaptive action approach, looking for example, seeing how the issue might be described or explained differently from different perspectives, understanding why that is significant to different people, and what's significant about that for different people, and then seeing where there could be commonality or easy wins, and starting to have those kinds of conversations. So I thought we could open it up here for people to perhaps suggest what they think might be possible themes that they might want to discuss or consider. I'll stop sharing my screen. And then open up the discussion. I mean, we have a few ideas, but I'm sure people on the call can contribute. Please feel free to raise your hand and speak too.
I mean, I'd love someone to challenge us and say, look, this kind of teaching space that I'm in every single day, and that's part of my bread and butter of my clinical or other expertise, what you've been talking about, wouldn't help me at all. I doubt that there is no space that systems thinking can't be relevant for, but it might be quite banal in a certain space, whereas in another space, you might say, gosh, some of these tools could really help. But I'd love to hear that. I mean, one of the things Stephen provoked with is on one of the last images, you see a person standing back from their art easel. I'm thinking of Kasemwana here and wondering, because I know he comes from an art background, and constantly recorrecting. This painting is not finished yet. There's this extra thing I need, or this extra thing. So one of the ways we try to model this in our assessments, which are rigorous and often involve 4 or 5 assessors in oral, written, and presented work. Stephen can explain more if you like later, starting off fairly gently in first year and then reaching quite a fever pitch with the end of the third year presentations that Dr. Partha convenes, with sort of adjudicators in a sense. So it's not a low quality exam environment, but it's built up with building blocks over 3 years. And so, of course, at the end, no one can pretend the stakes aren't high, but there's so many cumulative learnings, and their portfolio of learning they respond to with some new tested questions as well, and the requirement of new work before the final exam. But one of the things that fascinates is students that have the courage and maturity to say, look at how I failed here, or I could only see through a glass darkly how this worked in first year or even the first part of third year. And now I see that with these iterations, with these different lenses, I really understand that other piece of work. I've actually gone back to it. You can see my edits. I've gone back to something I did in second year or first year, and I've really improved it. And I'm going to keep this after I graduate from Wits or from this degree, because I really feel that this case study or this essay or this ethical issue or this debate or this annotated bibliography or this research hypothesis I came up with is much stronger now. I understand that article by Jerry Kovadia et al. From 2009 Lancet now. I could barely understand it in first year. This kind of way of judging people's learning, this form of assessment, is also based on systems thinking. And that might interest some of you. It is labor intensive, and it does require small group teaching as well, which is simply not possible for some of you, I know. But it is more real world like. Yeah, and it does. The students feel that their agency and their intelligence is also shaping the process.
I see
there's Anastasia.
Anastasia, yeah. And I know Daniela had her hand up, so please come in too afterwards, Daniela.
So it's fine if Daniela had her hand up before mine, she could go. Daniela, can I go ahead? So, you know, you made a comment. Actually, Catherine, it was Stephen that made that comment around having people making sense of a system in order to make it work for them. And, you know, it struck a nerve for me. So in my mind, and I'm sure many people are not speaking because this is a lot to unpack on several dimensions. And like you've mentioned rightly now, Catherine, it's not just the big picture system, you know, the broad system as we think of it, like, you know, the health system from a political perspective, from a, you know, everybody in its perspective. But like you rightly mentioned, and the way I'm unpacking this is that there are lots of microsystems within the whole big picture of systems thinking, and that there mustn't be a perfect learner-educator engagement that unpacks this at once. I think it's fantastic what the HSS is doing in terms of helping a very peculiar or unique set of students come out with skills that allow them to approach challenges without, you know, with those habits, those pictograms that Stephen put up, you know, wanting to step back, wanting to make meaningful connections, you know, trying to do a cause and effect, and all that. I think that's amazing. And I think it's something that we can also, you were saying building an engine in mid-flight. I think it is possible. When you look at the way people like, I mean, the rapidity with which flights to outer space and their carriers are now developed now, as opposed to when we were much younger, or the rapidity with which vaccines are developed, I think it's building on that concept of multiple microsystems within a big system. And so people can lean back and draw from a prior experience and explain. So for me, I'm looking at student engagement, and I know I've heard, and I'm sure other educators have also experienced, that a student who has gone through a very basic, simple system of clinical learning and assessments and comes out with an outcome that is sub-minimum and is given an opportunity to reappraise what led me to get to this point. And, you know, I like that first slide that Stephen shared, that iceberg of healthcare concepts. It literally can be applied to multiple scenarios. So when a student looks away from, I failed this discipline, or I failed to demonstrate this competency, and looks to all the microsystems that are beneath or are submerged, and then comes back at that same competency or that learning and makes sense of it and eventually passes it or demonstrates competence, we've had a couple of them who come back and say, you know, it's difficult to say now, but it is the truth that having failed last year and then going through this again has given me depth and insights that I would never have had if I'd passed the first time out and moved on. The point I'm trying to make is, from an educator's perspective, the small ways we could build this engine mid-flight is take small little systems within the big system, and not want to take a big bite, but just nibble away at the elephant, and with small engagements in small groups, with big engagements in big groups. If we start ourselves, and I'm speaking for myself, I mean, I found this series very interesting, and literally the last one I had to go and re-listen. If we start as educators to deepen and make ourselves more aware of what it means to be a systems thinker, then we could convert the most minute of engagements around a patient, or around an assessment, or around a learning objective, or creating a learning outcome, to an opportunity to generate a whirlwind effect, where students don't just think of, okay, fever and cough, this is what it is, but thinking beyond that, you know. And I think that goes back to that, what Stephen had shared around patient, family, community, how that works into different value systems, and how that works into different opportunities to engage, and, you know, all that. So not to go on and on, but I think this is very helpful. And the bottom line of what I'm trying to say is that it is possible, one small step at a time, microsystems within the big system, to engage with 1, 2, 3, and have them reassess their approach to whatever it is that they're dealing with. Thank you.
I can see you nodding away there, Catherine.
I'm elated. I'm so glad we tape recorded that. That's fantastic. And maybe Daniela would like to come in now, Stephen.
Yeah, perfect timing, Anastasia, that you went first. Because I'm just going to piggyback on what you've said. For the past 2 days, we've taken first years to Campbell Memorial, first year clinical associates, and these are students who initially started off at Bertha, that saw, you know, the ideal district hospital, ideal district primary healthcare system working, and they were, you know, just seeing how the standard could be great, how clinical governance can work. Some of the stuff I put on the chat, you know, interdependency and accountability, it's great. And then the past 2 days have been, I don't know if it's a culture shock, but it's left them feeling overwhelmed and not understanding what is going on, as well as the type of unethical behavior and just the systems failures that they were engaging with. So, Stephen, I think you're going to have a group of students that are looking forward to your session on Friday, that I don't know what you'll be discussing, but they want solutions. But the thing that I pick up, Anastasia, that you said is like smaller systems within the bigger system. And my question was going to be about this plane is moving so fast. It's and I feel like it's a political plane, and it's moving so fast that us who are the small little engineers in our small little systems, and we're doing our small little changes, are sometimes struggling to also keep up. There's also the plane of just the disease burden. It's moving too fast. And I think one of the things that, which is the session with the students, is just in trying to role model and trying to get them to think in a system. So I remember with first year, we tried to teach them a lot about the biopsychosocial, introduce them to the biopsychosocial framework, but starting obviously with the individual and then building up on the family and the community. But there's so many factors that happen so rapidly And as much as we are very good at the self-awareness, which, if I remember the diagram, getting to the I think, so what, it becomes challenging on the now what, because the political dynamics, the disease prevalence that warrants our attention at the time might feel as if we struggling. We always what's this thing? The target keeps on shifting. So that's why I asked about what are those key characteristics, the things that never change, that can be adaptable, but also that ensure that once we start, on this train, this plane, and should, the politics change, the financial situations change, or the disease burden change, we don't scurry over to just put out fires, but there's a little bit more sustainability in our systems. Because I think we do very well in creating policies and implementing some systems thinking, but the sustainability is what I worry about. So being adaptable, but not losing out on reaching the goals within transforming the systems.
I mean, the thing that comes to mind when you mention this is corruption, actually. And the example I used with my students was when you are pulled over by a traffic cop, what is your immediate reaction? So what do you think you're going to do? So they said, well, it depends on the response from the officer. So if it's clear that the officer wants a bribe, then there's certain ways in which they would then act. How would they offer this bribe without it being obvious that they're offering a bribe? So we were starting to talk about this. Well, in complex systems, patterns become entrained through repetition. So the idea of entrainment is that that the more that something becomes visible or practiced, it becomes part of our practice. So I saw that almost as encouraging, because it's the same idea. What kinds of patterns do we want to develop or train in our health system that have this ultimate shift in the way that people respond or practice in the face of power, for example? How is it, if we want to, for example, make our health system more humanistic and caring, we need to start by entraining that pattern in our students much sooner through the way that we teach and the expectations we put on. We leave through our practice, so that when they enter into these spaces, those are the kinds of things that they expect or reproduce themselves, that would lead to, maybe it's idealistic. So it's easy to see when it's a poor example, for example, like with corruption and paying bribes. But it's how did that thing come about, and then how do you start to dismantle it as a harder question, I think. But how can we use that same pattern in a positive way to reinforce positive practices? Yeah, I think that's one way of affecting change. But the other image that comes to mind is that this plane is flying, we're changing the engine. In many cases, we're just putting a band-aid onto where things are breaking, and so they keep breaking. They don't get fixed. But in our context, that plane is flying into a storm. That's how we described it, Catherine. So it's not smooth sailing either. And you're right, the speed at which it's moving, and also the environment in which it's flying, becomes more and more stormy. So how then, when there are unintended consequences, when things come from the side, even massive shifts and changes like COVID, or power insecurity, electricity power is insecurity, how does that then impact this, what we're trying to do? Because then those band-aids start to fall off. And that's what we're starting to see now. So I think, Catherine, I'll leave you with the last thought, and then we can see.
I just wanted to thank everybody for those inputs in the question and chat, but especially Daniela and Anastasia. I'm sure there are other people thinking too. And I wanted to see if maybe one day we could touch on the very sore studio, you know, that South African meme, don't touch me in my studio, of so-called scope of practice, how they get set up, who defines them, why they're so often normalized as being key to excellence, and, you know, liturgical boundaries of practice and all that. But actually, you know, if you go in an aeroplane, to finish the metaphor, the air steward or air hostess, whatever the correct nomenclature now, the air assistant, will inform you that while they might be serving you coffee and tea and bringing you water at night, they're also trained in international air safety, dealing with terrorists. They can do first aid, they can do CPR, they have a whole range of expertise. Just because you can't see it doesn't mean they don't have it, and they have to all cooperate. And the biggest air disasters that have ever happened in the world, when people have actually been saved mid-flight, it's actually been these people that have drawn together everything from pouring coffee to holding a crying baby to assisting with a very complex explosive. So this, I think, is exactly with the spirit of how Daniela writes her intervention above. Thank you, everybody. We can't wait to see the clinical associate students on Friday and to meet you all on the other side in one of the next podcasts. Thanks to Christine for hosting it and Stephen for his beautiful images. I do want to end on a very, very sad note. I've just received very sad news, and I just want to record it here today, that one of the greatest public intellectuals in South Africa, C.B.S. Makaiza, passed away a few hours ago. I was literally getting an email from him this morning about something we're doing in July, and apparently he's died of an epileptic seizure. And I just wanted to record great sadness at his passing. What a brave, courageous, often extremely contentious. He never backed away from an argument, often said sorry if he was wrong, was often right. Very powerful South African, passed away this afternoon, just a few hours after his last tweet. So on that very sad note, good evening, everybody.
Yeah, thanks for sharing that, Catherine. This is sad indeed. Okay, goodbye, everyone. Thanks again.